Okay, there, back on record now. So, I want to talk a little bit about the whole system and how it relates and what it does and that sort of thing. So, so we'll start right out with this is just a little anatomy and physiology related to the different parts. And I'm sure you've seen this 100 times, kind of thing, with A and P and so forth. But so we talk about the cerebral cortex, and look at the lobes of the frontal lobe, which is the motor and speech lobe, the parietal lobe, which is a sensory lobe, occipital, of course, which is your vision, and temporal, which is the auditory. So those are, the cerebral cortex lobes, and you, I'm sure from anatomy and physiology, you remember all that clearly. Well, maybe not, but anyway. So the next one is the limbic system. And the limbic system is a group of structures that lie beneath the cerebral cortex, sort of at the base of it. And they form a ring around it, a limbic ring. And this limbic system is the one that manages things like anger, fear, anxiety, pleasure, sorrow, all of those kinds of things. It's interesting because I always think about this is the part, that talks about love. You left your heart in San Francisco, and all those kinds of songs that talk about your heart. Your heart has nothing to do with emotions. It's all in your limbic system, but I don't think that goes as well in a song. So, just keep that in mind next time somebody says that to you. Oh, my heart's broken. Well, it's really your limbic system. So, so that you have the most accurate A and P information. So the diencephalon is the thalamus, hypothalamus, and the third ventricle of the part of the brain. And they regulate body temp and carbohydrate, fat metabolism, things like that. So, and we talk about the hypothalamus and related to being thalamus master glands and in controlling the endocrine system. The medulla oblongata is at the base, down at the base of the brain here. And that contains all the vital centers, such as respiratory, vasomotor, cardiac center, cough center, vomiting center. So that's a really important part of the brain, because what that does is it brings the sensory system from the central nervous system through there, which regulates the sympathetic parasympathetic system, release of hormones, and some of those things. So that, kind of an important system. Also down at the diencephalon at the base is the reticular formation. And the reticular formation exhibits inhibitory and excitatory parts. That is the one that promotes sleepiness and wakefulness. So that's where, we talk about that. The reticular formation is how we used to stimulate that in people that were in comas to try to get them. I mean, that was the part you were working on, by talking to them all the time and doing things for stimulation to get that center to activate, to wake the patient up. The cerebellum is I always think of them as the little shells that sit under the base of there. The cerebellum is the center for muscle coordination, equilibrium, and muscle tone. And that is the one that sort of manages your balance. It's the cerebellum that is so directly affected by alcohol. And that's why people do, for testing, they'll have you walk a straight line and touch your finger to your nose and all of that, because that is all regulated by the cerebellum. And if that's been affected, then that's where your balance issues and a lot of those factors come from that. The spinal cord, of course, comes up from the peripheral and intersects in that, and that is the impulses. It's sort of brings impulses from the periphery to the brain. And we've talked about the blood-brain barrier, which prevents drug penetration, kinds of things. So if we go on to the next slide, stop me if you have any questions or any, you want to ask anything, just chime in, just yakking away here. And the autonomic nervous system is a central nervous system, which consists of two parts. It consists of the brain and of the spinal cord. And we know what the brain and all of that stuff does. And the spinal cord is sort of the part that intersects and brings impulses to the brain for interpretation or action, and then is returned down to the peripheral system. So one of the things that, and again, I'm sure you've talked a lot about this, but is that the autonomic nervous system has really two parts to it. There's a somatic part, which is the afferent sensory, that brings the impulses from the periphery into the brain or wherever. And then there's an efferent, which is the motor portion, which then takes the impulses and the response from the brain back down through the spinal cord to the peripheral system. And so that's how that works. There's also the second part of the autonomic nervous system is the visceral system. The visceral system are the organs. Primarily in the body. And again, there's an afferent portion of that, which is sensory. The efferent portion to the visceral system is the sympathetic and parasympathetic system. So that's why all of those organs and so forth respond to epinephrine, norepinephrine, dopamine, serotonin, and in the parasympathetic system, acetylcholine. So that's how the whole thing sort of fits together, so that it is all integrated. So you have a somatic, which is your joints, muscles, pain, that sort of thing. And then the visceral, which cannot be controlled by thinking or whatever, it just happens. And that's part of the organ ones. So that's how the whole thing kind of fits together. So that when we look at the sympathetic and parasympathetic system, you will notice that there's a lot of terms that are used, and we've looked at a lot of these when we've been talking about different systems through the whole course, but this is what it looks like. So there's an anatomical version of this. The anatomical one is the cranial, sacral, and thoracolumbar. And I hope in your packet that you got a picture of where that all comes out. So the cranial sacral is part of, anatomically, is the parasympathetic system. And that's where a lot of those nerves come out. The cranial nerves come out of the cranial sacral area to regulate sympathetic and parasympathetic. And the thoracolumbar is sympathetic. We don't use anatomical names very much in pharmacology, but that's where they come out. And that's where they exit out of the cord. The physiological part is parasympathetic and sympathetic, and we've talked about those terms. The pharmacological part is cholinergic, which is the parasympathetic, and adrenergic, which is the sympathetic. So when we talked about adrenaline, that's where the name adrenaline came from, was adrenergic, and that's part of the sympathetic system. Then the neurotransmitters, and we've talked a lot about neurotransmitters. The parasympathetic only has one neurotransmitter, which is acetylcholine, and the sympathetic actually has four, but the one I put here is epinephrine, and there's also norepinephrine, serotonin, and dopamine are all part of that. So if we look at neurotransmission and see what that looks like, there are two parts to neurotransmission. There is an electrical part and there's a chemical part. So the electrical part of this sort of talks about the presence of a specific chemical, and can receive information and all those kinds of things. So that is related to action potential and the movement of sodium and potassium across cell membranes, which creates that difference. The chemical response is the actual synaptic junction, and it creates a bridge. And I'll show you more on the next slide how that all kind of fits together. So when we look at, go on to the next slide here, cholinergic transmission. And then again, cholinergic is the pharmacological name for the parasympathetic system with its only one neurotransmitter, which is acetylcholine. So when we look at how acetylcholine is made, where it's stored, how it's released, in its action, in its inactivation, that's what we're kind of talking about. So I'll go through what it does, and then I'll go out to the whiteboard and I'll kind of try to show you how the whole thing all fits together. So I started with cholinergic first because it only has one neurotransmitter, and I thought that would be easier to digest for the first time. So the synthesis part of acetylcholine, it's synthesized in a reaction catalyzed by cholinesterase. Now, you don't, in terms of, this is just sort of some background information. I'm not going to ask you how all of that happens. I just thought, you know, that's where it comes from. It's stored in vesicle packets, which are off the ends of the synapse. And I'll show you the picture. I'll draw you a little picture of that. So once it's made, then it's stored there. So the release is created by the action potential at the ends of the nerves and creates, so the acetylcholine, the action is it creates a bridge to allow the sodium and potassium to cross over that synapse. Otherwise, they'll fall down through the hole. And then the inactivation is it's inactivated by the enzyme acetylcholinesterase. So let me kind of go out and show you what that might look like, hopefully. So what we have here is we have the receptors. These are parasympathetic because we're talking about, or cholinergic, we're talking about those. And over here we have potassium. And we have sodium. And these are running, they're running to get to the synapse. So the sodium potassium is the action potential. So stored in the vesicle packets off the ends of those particular receptors is acetylcholine. So in the vagus nerve, and the vagus nerve is part of the parasympathetic system. So when the vagus nerve is stimulated and it creates this action potential, acetylcholine is here. So it's stored here. So when this sodium potassium get up here, rather so they don't fall down through the synapse, acetylcholine is released and it makes a bridge across the receptors to allow the sodium and potassium to cross over. And then over here is where you get your action based on whatever it is that you're doing. So the action occurs over here. Once acetylcholine has done its bridge thing, it is inactivated by acetylcholinesterase, which is this little thing right here. And it just comes up sort of like a little Pac-Man thing and it eats it. And then you go back to a normal state. So do you have any questions about that, or that looks like? So that's the parasympathetic system. So the adrenergic transmission is a little bit more complicated in that there are more ways it can be inactivated and sort of different ways that it works. So let's look at that. So we look at, for this system, this is the sympathetic. We look at the synthesis, storage, release, action, and inactivation. So again, this is a little bit more. Adrenergic transmission is created through catecholamines. And remember, we talked about catecholamines being the general term for epinephrine, norepinephrine, serotonin, and dopamine. So they're produced, synthesized through the system of norepinephrine and epinephrine. And I'll draw you a little picture here. And there's different things that happen to do that. And let me show you how that works. So here, this is through, and this is related primarily through the chemical steps of diet. So over here, and I'll, you know how this is kind of difficult to draw. It starts with tyrosine. And those are the chemicals in foods and things like, you can't take MAO inhibitors, you can't eat diet high in tyrosine, which are things like chocolate, red wine, some cheeses, all those kinds of things. So that's where that comes through. It comes through a diet. And then there's an enzyme called tyrosine hydroxylase, which is, and again, it's not anything you have to remember. It's an enzyme. It converts that to DOPA. And again, you don't need to memorize this. I want to show you, this is particularly related to Parkinson's, a lot of this. So the tyrosine is converted by an enzyme to DOPA. And then there's another enzyme called DOPA decarbylase, again, which is another enzyme. And that makes dopamine. So dopamine is one of the first neurotransmitters that's made through the diet, if you will, so dopamine. And then that is converted through another enzyme called dopamine B hydroxylase. So again, an ACE, so it's an enzyme. And that makes norepinephrine. So norepinephrine is the second neurotransmitter to be made from tyrosine. Then the norepinephrine is converted through another enzyme called methyltransferase, again, an enzyme, and you get epinephrine related to that. Then that epinephrine is stored in the adrenal medulla and released into the bloodstream when you need it. And again, you don't need to memorize this, but I just wanted to show you what you eat is how you get all of these things, the DOPA, the dopamine, norepinephrine, and epinephrine. And then serotonin is made a little bit differently, but that's how those are created related to that. So that's a synthesis of all of those neurotransmitters is through starting with the whole diet of tyrosine. It's stored in different places. As I said, the storage of epinephrine is created in the adrenal medulla, released directly into the bloodstream. Norepinephrine is stored in vesicle packets in the periphery, very similar to acetylcholine. Serotonin and dopamine are stored in the brain. Those are both brain neurotransmitters, and that's the only place they are. So that's where they're stored. The release is the action potential. So again, fight or flight, whatever that is, whatever you need, sodium, potassium. And it goes across the bridge just like the acetylcholine did to make the neurotransmitter, and then you get the activation on the other side. And the action for adrenergic is alpha and beta receptors. And we talked about the alpha receptors being located in the blood vessels pretty much. And the beta ones are located primarily in the heart and kidneys, and beta 2 in the pancreas and lungs. So that's where the primary adrenergic receptors are. And we know what happens because we've talked about that and class, and we've done respiratory and cardiac and all that. So again, fight or flight. So that's the action that occurs with that. Now, the inactivation of the adrenergic neuroreceptors is a little bit more in depth. It happens in 3 parts. And again, I will go out here and draw the parts for you because I think it's a little easier to see what happens. So the first one, number 1, I think my drawing would get better but it doesn't, is that again, we have our adrenergic receptors here. And the bridge has been created by either epinephrine, norepinephrine, depending on where you are in the body, but there's our catecholamine bridge, if you will. The first way that this is inactivated is through enzymes. And there's actually 3 of them. And it depends, they all have their own particular enzymes that they use. One is MAOA, monoamine oxidase inhibitors. And there's an A version and a B version. So they go in and they'll eat that enzyme depending on what it is. The A version usually eats epinephrine and B's norepinephrine for that. Then this third one is another one that eats enzymes, and that is called COMT. And you might recall COMT is the enzyme that we talked about when we talked about bronchodilation and wanting to extend bronchodilation. So if we could block this COMT enzyme, it created a longer acting bronchodilation medication. So those are the 3 things that from an enzyme point of view eat the neurotransmitters in the synapse. So it's MAOA, B, and COMT. So that's the first step. So, and that's the one that's the most active. So when you give we talk about using an MAOI inhibitor, it, blocks the A, it may block B. And what happens is that doesn't allow these enzymes to eat the neurotransmitters. The second one, number 2, is reuptake. And reuptake is a process, and it's primarily used for norepinephrine. And what it is here is your receptors. Remember, norepinephrine is stored in vesicle packets off the end of the neurotransmitter, or excuse me, off the end of the receptor in the periphery primarily. Norepinephrine is pretty much a peripheral neurotransmitter. So once norepinephrine does its thing, there's a process called amine pump. An amine pump is sort of like a sump pump. Now, I don't know if you know what sump pumps are. Sump pumps are things that people have in their cellar to keep the water out. And what they do is they have a little float on them, and the water gets to a certain point, they kick on and they pump the water out. In this situation, what it does is when the norepinephrine gets to a particular level, the amine pump will kick on and its hose will pump it back into the vesicle packet. So there's always a supply of norepinephrine available. So that's called a reuptake process through a process of the amine pump system. And that's how that works. The third one, as long as I've got the thing up here, the third process is a diffusion process. And anything left over is picked up by circulation and metabolized in the liver. So that's of the 3, that's the least one. So the first 2 are the more important ones to use for that. Does anybody have any questions about that? Any comments? How that works or doesn't work or anything? Okay. So the neurotransmitters, we talked about these, the monoamines, and they're also called catecholamines, are the 4: norepinephrine, epinephrine, dopamine, and serotonin. Norepinephrine, just to kind of a little bit of what they do, norepinephrine is a very potent vasoconstrictor. And that's why it's out we talked about it being in the periphery. So when you talk about fight or flight, norepinephrine is released to cause vasoconstriction to pump blood to the vital organs. So that's what that does. Epinephrine, of course, is alpha beta, fight or flight, directly released from the adrenal medulla into the bloodstream as a first messenger. in most cases, because its message is to make a bridge. Then the action potential does the rest of the work. Dopamine is a neurotransmitter in the brain. And it's interesting because increased levels of dopamine are thought to cause thought disorder, schizophrenia. Decreased levels of dopamine cause Parkinson's disease. So the balance of dopamine in the brain is extremely important, because if it's out of whack, you're going to get one of those. So, and then serotonin is also found in the brain, and that seems to be related to mood disorders. People that have low serotonin levels tend to be depressed. And so we talk about serotonin reuptake inhibitors when you talk about psychotropic meds. Some of you probably have had psych or in psych right now, so you probably have talked a little bit about some of those. There's also a whole lot of neurotransmitters that are not related to they're more endocrine. They're not related to the sympathetic or parasympathetic system, and they're called peptides. Enkephalins and endorphins are related to morphine. They bind to the same receptors as morphine does, and they're related to that whole feeling of second wind, euphoria, pain relief, all those kinds of things. So those are peptides. Substance P is kind of an interesting thing. Substance P has 11, and again, you just kind of say 11 amino acids to it. And it helps sensory nerves in the spinal cord. It sort of helps in, the impulse go up and down the cord. And one of the main places substance P is stored is in tooth pulp. So the whole question arises, what if you have dentures? You don't have tooth pulp, so where is substance P stored? And that's sort of a little question about, that people aren't really too sure, but that's, it's kind of an interesting thing. The thing with substance P that's of significance, and again, we talked a little bit about, or you guys have talked about psychotropic, is Huntington's chorea seems to be related to people that don't have enough substance P. And if you think about what substance P does related to the propagation of impulses up and down the cord, if you don't have enough, you lose all of your motor activity. And that's what happens in Huntington's chorea, where they have all of these bizarre chorea kind of movements. Oxytocin, of course, uterine contractions. Vasopressin is the peptide that regulates the antidiuretic hormone. And when you have decreased amounts of vasopressin, you develop diabetes insipidus, which is an endocrine problem related, it's produced because ADH comes out of the posterior pituitary gland. And somatostatin, which is an inhibiting factor, and that suppresses the release of insulin and glucagon. So it's related, and again, to diabetes. So those are the neurotransmitters of the peptides. And again, they're not related to the sympathetic or or parasympathetic system, but they function off negative feedback loops and the endocrine system. The other neurotransmitters out there are amino acids, and the aspar, glutamate, GABA. You might have heard of GABA related to, again, psych meds, because that seems to be, the production of GABA seems to decrease anxiety. And there's a lot of medications that will inhibit that so that your anxiety is not so much. But those are some of the amino acids for that. And then the other one is acetylcholine, which is part of the parasympathetic system. So I just kind of wanted to talk a little bit about those. Do you have any questions? That's kind of a quick overview of neurotransmission, but we're going to talk about Parkinson's disease, and that is a big factor related to the lack of dopamine in the brain. So I just kind of wanted to talk a little bit about that. Does anybody have any questions or issues or things related to that? Is anybody out there? I don't know. I don't see anybody.
Yeah.
Okay, good. I just wondering. I haven't. All I see is black screens. I don't really see anybody a few people, but.
Yeah, I'm here.
Okay, okay, good. I just,
right
kind
now.
of thing. So, just kind of looking at that. So, okay. So I'm going to let me go back out here and see if I can find the next one, which is Parkinson's disease. Okay. I just got to change stuff here for a second. Okay, here we go. So with Parkinson's disease, to look at, it is caused by an increased amount of acetylcholine and a decreased amount of dopamine. So if you look at the whole, go back out here. Is, if you look at, this is the balance in your brain. And so you want to have a balance of dopamine and acetylcholine. That's what keeps your brain functioning in all the body parts and so forth. If you have this balance is out of whack, and when the reciprocal, when the dopamine goes down, the acetylcholine goes up. And in this situation, it creates, this is a Parkinson's situation. The other part is when the dopamine goes up and the acetylcholine drops, you have thought disorder. So Parkinson's meds are aimed at increasing the levels of dopamine and decreasing the levels of acetylcholine. Thought disorder meds, which you probably have talked about in psych, decrease dopamine and increase acetylcholine. So this is Parkinson's, and this is, and I know we call it thought disorder, but this is schizophrenia, and this is normal. So your whole idea is to try to get this balance with actually both of these syndromes. So that's how that works. But we're going to talk about the Parkinson's part of this now. So you have an increased amount of acetylcholine and a decreased amount of dopamine related to that. Now, this is kind of what happens, they think, with Parkinson's. As you probably are aware, nobody seems to know exactly how, where, what, all of those kinds of things. So, so there's this stuff called alpha synuclein that it tends to accumulate. And when it does, it tends to destroy the dopaminergic neurons. And then you get these fibrils called Lewy bodies in the brain. And I got a picture on the next slide. I'll show you what that looks like. The causes seem to be genetic vulnerability. Now, is it inherited? No. And environmental toxins. So the cause is sort of known, but why it happens is not known. So this is what has, so there's the nucleus and the mitochondria and all, and again, so here's this stuff, and you get this aggregation around there, and it forms all of these damages, all of this kind of stuff, and you get these, and this aggregation creates what is called the Lewy body. And that's the one that tends to seem to be a problem related to all the symptoms of Parkinson's, because it disrupts all the neurotransmission part of this. So people with Parkinson's disease, symptomatology wise, have all sorts of things. If you'll notice, they have a mask like face. They lose their ability to smile and have facial expression. They tend to lean forward, they drool, they shuffle. They have what they call that pill rolling tremor, which is and I'll kind of show you. It's where they have this kind of thing where it's on, and it's usually bilateral, where they have this, and it looks like they're rolling pills, and that's what they call that from. So that's where that came from. So the whole idea, and that happens because they don't have enough dopamine to maintain the muscle, and then they have an excess of acetylcholine, which causes this cogwheel shuffling part. And we'll look at meds and how that all might help that. So again, there's two classifications of drugs that we use, and you have to use them simultaneously. We give drugs that are anticholinergics to bring down the levels of acetylcholine. Then you give meds that try to increase brain dopamine levels. That is difficult. And the reason it's difficult is because dopamine does not, pure dopamine, if you were to give it, does not cross the blood-brain barrier. So you have to transport it via some other mechanisms, which we'll talk about a little bit. And that's what makes it so hard, because the drug is there, but you can't get it to the brain where it needs to be in a good, proper way, if you will. So the anticholinergics by action, that they block the whole thing of acetylcholine, so that when it tries to make the bridge, the med takes up in that slot so that it can't create the bridge. So therefore you don't get the action potential across the neurotransmitter. Some of the things, nursing considerations, and we'll look at that. Nursing considerations is you have to be careful using it in children. We don't use a lot of anticholinergic activity in children with that. The other thing is you can't give it to patients with acute narrow angle glaucoma. And we'll look at that why in a second, talk about that. You need to start slow, build it until you get a therapeutic level. And this is one of those wean on, wean off meds. So if for some reason you take them off the anticholinergic, you just can't stop it. You need to wean them on, wean them off. You do get tolerance from this, so that sometimes you need to increase the dosage from it. And it should be administered with meals, because it causes a lot of stuff. When we look at what I wanted to show you, the we've talked about this a couple times, what anticholinergics do, and it creates this whole thing of red as a beet because it causes vasodilation, hot as a hair because it alters the temperature regulation, blind as a bat, and that's where that narrow angle glaucoma comes in, because it doesn't allow for fluid to leave the intraocular area, so therefore you get increased intraocular pressure. So that's a real important consideration when you're going to use an anticholinergic. Dry as a bone, it dries up all your secretions, and mad as a hatter. It does have some psych stuff with it. So if you're going to use an anticholinergic, it's important to consider those for patients, because a lot of times Parkinson's patients are older patients, so they're going to have a lot of these problems to start with. So things to be thinking about: mental functioning, because they're going to have blurred vision, they're going to be drowsy from this. You get an increased chance of heat exhaustion. So of course that wouldn't be a problem today, but in the summertime when it's so hot, you have to be really careful with these patients to watch them. Causes a lot of orthostatic hypotension because of the vasodilation. So, red as a beet. So that's one of the things. And you can use ice, hard candy, things like that, because their mouth is very, very dry. So that's one of the things that you want to think, and make sure that they have their eyes checked frequently, at least every 6 months, to watch for that intraocular pressure. So that's some of the things related to that. So that's anticholinergic activity. So those are, again, some of the nursing considerations to look at that. So that's the first classifications of drugs. And here's the drugs that we use most common. We use Cogentin and Artane, and you probably might have seen these. We use a lot of Cogentin around this area. Seen these meds used as anticholinergics in Parkinson's disease and with schizophrenia, because once you increase or try to decrease levels of dopamine and thought disorder, you have an increased level of acetylcholine. So very oftentimes they have to use the Cogentin to bring those levels down for that. So those are the common meds for that. The second classifications are drugs that affect brain dopamine levels. And there are several of those. There's drugs that increase brain dopamine levels, drugs that actually release dopamine, dopaminergic agonists. These are meds that will allow what dopamine is already there to stay there. And we talked about these, the COMT inhibitors and MAO-B inhibitors. So they will inhibit the enzyme, or they from eating dopamine in the synapse, so it stays there for a longer period of time. So the med that is the sort of the standard, if you will, is levodopa. Now, levodopa crosses the blood-brain barrier and it crosses intact, if you will, and then is decarboxylated. And if you remember that term from the triosine, from all the decarboxylated into dopamine. The problem is that takes a long time for that process to occur, anywhere from 2 to 3 weeks. So you don't get an immediate relief from any kind of the symptoms with levodopa. And sometimes it takes 6 months to get a therapeutic response to that. And that is because it does cross the blood-brain barrier, but in such small amounts that it just takes a very, very long time. And patients get very discouraged with that. So the things that are important from a nursing consideration with levodopa is that you should not give this to patients with undiagnosed skin lesions, because it activates melanomas, which is an interesting thing. So if you're going to give somebody, it's, again, elderly patients, if you're going to give them any kind of a levodopa product that does that, make sure they go to and have a derm consult and checked over and make sure that they don't have any melanomas, because you could actually activate all of those. You have to give it before meals, and you have to avoid foods high in vitamin B6. Vitamin B6, those are pork products, beef products, liver. I don't know why anybody would eat liver, but bananas and ham and eggs, those are the ones that are high in vitamin B6, because vitamin B6 will decrease the effects of levodopa. And it already is having difficulty getting to its place and making enough of it. So that becomes an issue with diet for them. It's also important to let the patient know that all their urine, their bodily excretions, sweat, urine, will be darker in color, so that they don't think, oh, this is bad. Other things levodopa can do is they will increase cardiac dysrhythmias. And again, in elderly patients, they have a lot of cardiac dysrhythmias. It may aggravate pulmonary conditions. It can precipitate an acute attack of glaucoma. And you can get a GI bleed if you have a history of peptic ulcers. So, that's not a great med, but, what do you do with all of that? So the second medication that is part of this is a medication which is a combination of levodopa and carbidopa called Sinemet. And what this does is it has a decarb, and again, you know, that's why I drew all of that decarboxylase, because I knew you're going to talk, I knew I was going to talk about them again. It's a combination of levodopa plus decarboxylase inhibitor, which is carbidopa. So what that does, I mean, you could go through the whole chemical part of it, but basically what that does is it prevents the levodopa from being broken down before it gets across the blood-brain barrier, which then allows more levodopa not to be made into other things. So it allows more dopamine to be produced through levodopa in the brain. So that's basically what happens with that. The nice thing about this is that you don't have to watch the diet. So you can give them vitamin B6. It doesn't affect that because the carbidopa takes care of that. It's a carbidopa version of that. So that is a really good drug. The only other thing that levodopa and this Sinemet do is it will cause some nausea. So you have to, and people get so discouraged with the side effects of these medications that they tend like, oh, I'm not going to get any better. So that's it. But so a lot of people now, rather than being on levodopa, have been switched over to the levodopa carbidopas to increase the amount of dopamine available in the brain. So that's where that is. I'm doing on my time here. Then we have a dopamine releasing drug, and this drug is Symetra. And again, its action is it stimulates the production of dopamine, and it also activates the dopamine that is already stored in vesicle packets. So in other words, it doesn't make any, it helps make a little bit more, but it helps release it better. So you have a better release of the medication that's there. You have to give it with meals to decrease nausea. And you start low, bring it up, all the kinds of things. One of the things you have to be careful of with this medication is that if you have, it will activate fertility. So restoration of fertility. So, I mean, if you have all the parts and everything, I don't mean kind of thing. So you just want to be careful if you're going to give it to somebody that may not want any more children or whatever, that could be an issue. You can't give oral estrogen with this because it stimulates prolactin secreting, and you should perform a pregnancy test every 4 weeks with this. So kind of thing. So those are, some of the things related to that. So let me go on. And dopaminergic, these are the same kind of thing. Have the same kind of problem, Paradol and Mirapex. They're agonists. Again, they just promote the dopamine that's already there. Requip is another one. This was withdrawn because of heart valve disease, Permex, just to kind of tell you that. Then we go into the COMT inhibitors. And the COMT inhibitors, Tasmar and Comtame, are the two that, and again, you just give these. You don't give them together. They are one or the other. These are the two meds in the category, and they block the COMT so that it doesn't eat the dopamine. So that allows the dopamine to stay longer in the synapse. So it doesn't produce any dopamine. It doesn't do anything. It just helps the dopamine that's already there stay there longer. So those are the medications with those. The other one is the selective AOB, which is the Carbex. The one thing to think about with it, and this just blocks the B part, you have to be careful that you don't use a B and a COMT together, because what that does is it blocks the entire inactivation system of the adrenergic system. So it allows for the accumulation, and you can get into hypertension crisis and all sorts of problems related to that. So you don't give MOBs and you don't give COMTs together. So that's the thing related to that. The surgical treatment, and that's the other one for that. The surgical treatment is, they have tried to go in and find a spot that, and they try to, ablate that spot through ablation. They've also tried fetal tissue transplants in Canada. It's worked a little bit, not a lot. There just isn't a lot of treatment for this. And, I think about Michael J. Fox as being one of the people, and then Muhammad Ali had it as well. It's people that have that. So the last thing I'm not gonna get to epilepsy today, but I want to talk about myasthenia gravis as a sort of disease, if you will. Myasthenia gravis is a disease of the upper part of the body, and usually from the respiratory system up. And what happens with this is that patients are short on acetylcholine. They don't just have enough acetylcholine. And remember, acetylcholinesterase is what eats acetylcholine. So you give an anticholinesterase to block that enzyme from eating acetylcholine in the synapse. So what happens with myasthenia gravis patients is they have difficulty swallowing, chewing, they don't blink their eyes, because all of this becomes, the upper part of the body just doesn't respond muscle-wise. These patients usually die from respiratory depression, pneumonia, because eventually what happens is you lose the ability to breathe even with all of this. The drug in this category to help with this is prostigmine. And prostigmine is an anticholinesterase. So it eats doesn't allow cholinesterase to eat the acetylcholine. Nursing considerations for this med, it comes PO, and the patients have to learn to titrate it based on what they want to do. So usually they get up in the morning, they'll take it a half an hour before they eat breakfast. That gives them the ability to eat. They take it for activities through the day. So it becomes a situation where the patient manages the medication based on what their activity is for the day. So that's what, and prostigmine is the drug of choice for myasthenia gravis. So it's, again, not a great, but patients do quite well with the prostigmine for that. Have any questions or things you want to ask, or? I'll stop there. The quiz next week will be, which is your last one, your number 10. Finally, we got to number 10 quiz. Will be on just what we talked about today, which will be neuro A&P, myasthenia gravis, and Parkinson's disease. So there'll be 10 questions related to that. And I'm not going to use Respondus for the quiz, for the 10th quiz. I'll just post it out there and you can take it next Friday morning at 9 o'clock. So does anybody have any questions or issues or things before I end today? I will email those, the 5 of you who I have not received case studies from, just to make sure I haven't missed them. And just so that they're due at midnight tonight, by midnight. So I have most of you, but I do have 5 that I don't seem to have. So.
Dr. Ness, you
yes.
just want us to take a picture, like a screenshot of the questions?
Yes, and some people, what they've done, different people have done different things. Apparently, some of you had sent me an actual transcript. There's a way to go in and actually print a transcript of all the things that you've done on ATI. Some people have put the answers in a Word document and sent them. Some people have sent me screenshots. It's whatever works for you.
I had to send it in a Word document because my pictures want to upload.
Yeah, that's it. The pictures take a lot of space. and they fill my email very quickly, which is not a problem because I can download them on a pen drive. But, if you just want to just go through and put like respiratory question 1 and what your answer was, because I have the master, if you will. So I can, if you want to do that, that's fine.
The report, that's how I sent it to you. That was acceptable. Is that
Yes,
correct?
yes, it is. Yes, it was acceptable. Yes, I was going to say that was it was a transcript, and that
Yeah.
looked, and I could see the whole thing, and so that was fine. Yep, that worked out fine for me.
For those who would like to do it that way, the easiest way to get to it is when you're in My ATI, it has the results tab. If you just select the results tab, it'll say download report over to like the right of the screen, and that's just gonna download it all, and you can send that. to
And
her
that's
that way.
fine. I mean, I got everything, but I don't, I just wanted and that showed up in the farm, and that's all I wanted. So I was good with that.
I do have a clarifying question about
Sure.
the packets that you sent out. I may have misread what it was specifically, but I thought it was just the remaining PowerPoints for the lectures. Was it something separate that like, what was it different that you actually mailed to people?
The package, you mean, that I sent?
Yeah.
The
Yeah.
packets I sent to, I asked for people that wanted packets to send me an email. And I got like, I don't know, 15 or so emails that people wanted packets. So what I did was I took them to the college and had Heather print all the remaining packets and all the information for the lectures. And then we mailed them in the mail to people that asked for them.
Okay, so it was just like the PowerPoints for lectures. It wasn't like a study guide or review or anything like
No,
that.
no. It was just the packets that had the, objectives, and some of them had course outlines and PowerPoints and all the pictures that I send out. So I just sent packets related to that. Yes.
Oh, okay, I wanted to make sure. Thank
Yeah,
you.
sure. No, that's good. Yeah. And I'm glad you asked. Thank you.
Dr. Hess,
Yes.
did you want just the ATI exam grade, or did you want the report with the itemized list?
I
of how
like the
we did?
report for the itemized list. And, and again, the reason I like that is because then I can see maybe, maybe some of you or a lot of you didn't do well in a particular area. Maybe I need to emphasize that area more. So it's helpful for me from a instructor point of view to see areas where students didn't do well, and maybe I can enhance some of my lecture related to that. For me, it's an evaluation piece. I can kind of look at that. So if you can, I don't know if I can see it on ATI, I can see your score, but I can't see individual student responses. I can't see that. I just get a score by name on my ATI part.
Dr. Hess,
Yes.
if my name is on one of the people that need to send an email reminding, I sent you my case study stuff, Word documents with my ATI report from from
Oh,
So you don't
okay,
have to
good,
email
thank
me
you.
to
All right,
say-
I haven't looked, because I had my email shut off here. So, I can go through that and look. Okay, thank you.
All right, no worries.
Yep. Any other questions or issues? I recorded this, so I will try to get the recording up this afternoon so that you can go back and look at it. Because again, not everybody was on today, so hopefully we can have enough to do that. So any other questions? So anything else anybody would like to know? Okay, very good. Have a good day. I will let me know, send me emails if you have questions about anything or need to talk about anything. So
Thanks, Dr. Hess.
yes,
you.
thanks. We'll see you all again. We'll see you all again soon. I hope you all had a nice Thanksgiving too. So,
You too.
okay, take care.
Bye.
Thank
Okay, bye-bye.
you.